everybody. Thank you so much for joining us all again this evening for another Restless Presents event with Eleanor Moyle and Dr. Claire from our menopause partners, My Menopause Centre. We're also joined this evening by Eleanor Gardner, a pelvic floor expert, and hopefully also by Sue Macon, a sex therapist who is having an awful lot of tech trouble logging on this evening, but we will hopefully have her join us shortly. This evening's event is the third in our menopause series with our partners, My Menopause Centre. We've already covered the menopause in general, as well as all things HRT. This time, it's time for us to cover one of the most taboo topics of all, your sexual well-being and the menopause. Painful sex, loss of libido, and vaginal dryness are some of the most common side effects of the menopause, which can so easily be treated, but too often women are too embarrassed to talk about it. This evening, and let's hope it's not for one night only, there's no such thing as embarrassment or shame, and we're going to cover all of it. So before I hand over to Helen and Dr. Claire, who will host this evening's event, I wanted to remind you of a couple of housekeeping points. Please post your questions in the chat box at the bottom of your screens. Feel free to post throughout the presentation, and Helen will come to the questions at the end. And any tech issues that you might be having, my colleague Gaetano is at your service to help. So please just put any questions that you might have also in the chat box. So now over to you, Helen and Dr. Claire.
Brilliant. Thank you very much, Ash, for that very warm welcome. And thank you everyone for joining us this evening. Dr. Claire and I believe that the best way to smash a taboo is to talk about it. And while there are still way too many taboos around menopause, there are even multiple more times taboos around sex and menopause, and it really shouldn't be that way. Various studies have shown that around 40 to 50% of women experience a loss of sex drive in menopause, and over 1 in 3 experience vaginal dryness related to menopause. And I know from speaking to Dr. Claire that this is something that she believes is very much underreported, and that the incidence is probably higher. And Claire, I know we'll come to that in our conversation. We also know that a lot of women are searching in Google for answers to their questions around vaginal dryness, around loss of libido. And our sexual well-being is a key part to our physical and our mental health. And as you'll hear from Dr. Claire and from Eleanor, and hopefully from Sue, there are solutions out there. There are things that you can do to have a really fulfilling and enjoyable sex life in your 40s, 50s, 60s and beyond. And it's really important that there is no embarrassment around this. And I know it's easier said than done. If you'd asked me a year ago if I'd be on a video call with Claire talking about vaginal atrophy, vaginal dryness and painful sex, I would have said no, but it's too important not to have this conversation. So Claire, if we kick off with a question to you, and this evening's conversation, we're going to split into 2 parts. In the first part, we're going to speak about gynecological symptoms that can get in the way and stop you from enjoying sex. And in the second part, we'll talk about loss of libido or loss of sex drive. But I think we can all agree it's fairly hard to enjoy sex if it's painful in the first instance. So Claire, we mentioned that stat from the British Menopause Society, where they see that over 1 in 3 women say when they're surveyed that they experience vaginal dryness. What's your experience of that in your clinic and in the patients that you see?
Yes, hi, good evening, everybody. It's so great to be here again. No, absolutely, Helen. Although that statistic, that's a third of women, is really quite high. In reality, I think it's far more common than that. You know, when you actually ask women about symptoms, the vast majority, I would say, at some stage during the menopause transition, will experience some form of, the medical term is urogenital atrophy. And what's going on is we all know that as you go through the menopause, we lose estrogen. And what people don't realize is that estrogen is really crucial for maintaining normal health of the vulva on the outside, the vagina on the inside, and your bladder. And hence women can experience symptoms of vaginal itching, scratchiness, dryness, soreness. You can get little splits on the vagina, so, and at the vulva. So unsurprisingly, it can make sex really painful, or uncomfortable, or dry, or even just not pleasurable. That builds up worry, and so lo and behold, that has an impact on sex drive and libido.
And Claire, when patients come to see you, is your sense that they have an understanding of what's going on with their bodies, or when they're speaking to you about the vulva and about the vagina, is there more work that we need to do to help people understand what's going on with the body and what are the causes of vaginal dryness, so that then you can help better guide people or signpost them to solutions?
Yes, Helen, that's a really, really good point. Absolutely. So, and I'm not sure if you remember, but last year there was a study published in The Guardian showing that actually women just aren't aware of the names of different bits of anatomy. So I think in one of the answers to your question is women often refer to the vagina as that general genital area. And so this is from our website, My Menopause Centre. And this is a diagram to show the vulva. So this is the area on the outside that often women refer to as the vagina, because I mean, why would you know what everything is called? It's not like everybody gets an anatomy lesson at puberty. So this is a diagram, and just to orientate you, this is if you're lying as if you're having a smear. And so you can see your bottom, your anus down at the bottom, and at the top will be the mons pubis, which is the hairy bit, the clitoral hood, the clitoris. There's the urethral opening, that's the little tube that drains from the bladder. The vestibule, or another name of that, is a sort of perineum. That's the tissue surrounding it on the outside. And then you can see the vaginal opening is actually down at the bottom. So people often say that they're having painful sex, or sex has just lost its pleasure. And it's not till you actually say, look, I'm really sick. We just have to be graphic. Where exactly do you mean? And often what happens is the stretch at the vaginal opening, which is another name is the introitus, the stretch is lost there. And so there's often initial pain on penetration because the elasticity is gone. You know, that initial penetration can be painful with heterosexual sex, or, you know, if you're using a sex toy, for example. And then the second part of it is what's going on in the vagina itself. And Helen, just to continue the anatomy lesson, if we put then the next slide up, we can see this is a different view. So this is as if you've cut a slice through a body. And you can see then the vagina is the sort of tunnely tube at the bottom. And then we have the cervix, which is the neck of the womb, and then the cavity of the womb, the tubes and the ovaries in pale blue. And so you can see on the right hand side, where the diagram is a darker blue, you can see that the vagina on the inside is thinner, it's dry. If you compare it to the brown side, which is this sort of estrogenized premenopausal side. So that's showing that what's going on the inside is the vagina, the inside bit is thinner, it's dry, it feels drier, you lose the elasticity, you lose the stretch, so the vagina can become shorter. And again, that's going to sort of contribute to painful or unenjoyable intercourse. So to recap, the vulva is the bit on the outside. The entrance to the vagina, the introitus, is often where a lot of the pain and the little splits and the skin are felt. And then the vagina is on the inside. And the whole area, sometimes it's one bit, sometimes it's another bit, can be affected by loss of estrogen.
And Claire, I've taken thank you very much for that. And I've taken the slides down now. So is this something that some women, all women, most women can expect to experience as they go through the menopause transition, so into post-menopause?
Yeah, so I'm not going to say 100% because it's very depressing statistic, but I would say the majority of women who I speak to at some stage are experiencing some symptom, and it might be really mild. It might just be a little bit of dryness, needing a bit of lubrication, and that sorts it out. But for other women, it can be really debilitating and have a really significant impact on quality of life and libido and relationships, sense of well-being.
Yeah, and so what are the solutions then? What are the treatment options for women who are experiencing vaginal atrophy or vaginal dryness?
Yeah, no, so I'm really hoping that Eleanor's going to speak in a second, and I'd really love to bring Eleanor in to talk about the non-hormonal aspects of treatment, of which there are many. If I just focus from the medical point of view just for a second, it makes sense that if it's loss of estrogen causing the symptoms, giving a little estrogen back just to the vulva, just to the vagina, can really, really help. It can honestly be, it's probably not over dramatic to say life-changing. And so on prescription, you can get little tiny vaginal pessaries. This is a Vagifem applicator, and on the bottom, there's a little tiny white tablet that you can insert into the vagina. That's great for vaginal dryness, for getting the elasticity back inside. There are other slightly larger pessaries. This one's called Invagis, which I don't know if you can see. It's a little waxy pessary. It's more like a Canesten pessary that melts and gives quite a good moisturizing residue. Some people like that one. Or there's cream, there's gel that you can apply there. Cream's quite good actually if the issue is loss of stretch at the entrance to the vagina, because you can, if you feel comfortable, you can sort of swish the cream around at the entrance. Or some women prefer actually to have a ring fit, which is a little rubbery vaginal ring that secretes estrogen the whole time and can stay there for 3 months. So lots of options that I can prescribe. DHEA is intrarossa, that's a precursor to testosterone. And there's evidence also that that can also help treat these symptoms, and as well as the estrogens, increase sexual pleasure. Yeah. I think we're going to bring Eleanor in to talk about the non-hormonal moisturizers and lubricants also that can help. And of course, not forgetting HRT, you know, bog standard systemic HRT can also help a lot of women if they don't want to use something vaginally.
And Claire, just before we come to Eleanor, because I think one of the questions that we sometimes get is, can I take a vaginal estrogen or some of the other products that you mentioned in addition to HRT as well? Or is it too much estrogen to take?
Oh yeah, no, that's a really good question. So it's absolutely fine to use a vaginal estrogen as well as HRT, because you hardly absorb any of the estrogen from the vagina into your system. I think there's a statistic floating around saying that if you use a vaginal estrogen for a year, you get the same amount of estrogen as swallowing 1 estrogen tablet into your system. Your blood levels never go above a postmenopausal blood level for estrogen. And there's lots of evidence showing that there is no increased risk of breast cancer from using a vaginal estrogen, no increased risk of heart disease, no increased risk of blood clots. A lot of women read the leaflet, and you know, why wouldn't you? It's a responsible thing to do that comes with your vaginal estrogen. But actually, law dictates that they have to put the risks of swallowing estrogen into the patient information leaflet on the vaginal estrogen. So lots of people get quite anxious about taking it, and many people don't when they read that leaflet. But there is lots of evidence in summary showing the safety of vaginal estrogens.
Brilliant. And then last question, maybe before bringing in Eleanor. The products that you mentioned, Claire, are they all available on the NHS as well as NHS prescription?
Yes, as well as private. Yes, no, absolutely. Your GP will be able to prescribe them. The only one the DHEA pessary intrarossa. It's relatively new, and so in many parts of the country it's only prescribable by a specialist such as myself, a menopause specialist or gynecologist, but all of the vaginal estrogens I've mentioned can be prescribed by a GP.
Okay, brilliant. And I should say, and we'll pop it into the chat or send it out afterwards with the restless information. We've got a lot of information on our website about HRT and the different types of HRT. If you weren't able to keep up with all of the different products that Claire mentioned, you'll find them all there. So Eleanor, Claire mentioned obviously that there are lots of non-hormonal options, and we know that you've got so much expertise in this area. On your experience, Eleanor, what would you recommend for a woman who's experiencing vaginal dryness?
Thank you, Helen and Claire, and lovely to see you all here. I thought that was really well described, Claire. We are always signposting women to as a first port of call, go back to your GP and talk about getting some vaginal estrogen prescribed, because it really is, as Claire said, life-changing. But I think that as a first stepping stone, there are also other products out there that can really help either complement your use of a vaginal estrogen, or for some women as an alternative, when considering all their options, they wanted to choose a non-hormonal product. So I think the first thing we probably need to talk about are vaginal moisturizers and lubricants. Now, whereas an estrogen-based product is re-estrogenizing that system to replace what is missing, a vaginal moisturizer should be a water-based product, and what it's doing is rehydrating the tissue by delivering water back to that tissue. So it should just have bioadhesive gums in it, so it will stick to the vulva or the lining of the vagina, and then water will move from the product to rehydrate the tissue. Now, what's happened over the course of a number of years, as there's been a lack of investment in women's health, and big companies used to make moisturizers and lubricants that were cheap and slippy, but didn't really consider whether the ingredients in them were really good for gynecological health. And so when I first moved from devices into pelvic health, I was researching lubricant and moisturizer composition and really trying to understand what it was we should be using. And that's when I came across the Yes Yes company. And I now do have a relationship with them, and I'm an ambassador for them. But I took on that role because I really believe they're life-changing products for women. They obviously do a lot of work with women postmenopausally. So they have a range of products that are organic, non-hormonal, and they really have tried to keep ingredients to the bare necessity. So they haven't put unnecessary extras that you would see in ordinary cosmetics to really preserve the health of the vagina. So they've got a vagina moisturizer, which either that light isn't very good, but it's the white tube, and you can either get it in a tube or in a little applicator. And a vaginal moisturizer is going to be there for day-to-day hydration. So it can be used alongside your hormone. So if you're using something like Vagifem and you find that on day 2 or day 3, you want some more, you're feeling you're a bit dry again before your next dose, then you can use your vaginal moisturizer alongside, or you can just use it daily to just keep hydrated. So it's a long-lasting product, and it's there just to keep comfort and hydration of the vaginal tissues. Lubricants are designed to be slippier over shorter periods of time, so they're really designed for sex. And I know some women do like to use their lubricant as a moisturizer, but actually they are formulated slightly differently so the moisturizer has a longer action. So the Yes company lubricants, which I like to recommend, are the water-based lubricant, which is going to be a very natural feeling lubricant, and the oil-based lubricant, which is very soothing and nourishing. And actually the oil-based lubricant is a lovely product if you're getting, as Claire described, those sort of micro abrasions on the vulva, and that's a really nice soothing product for that. And the what's really important when you're, I've just described the Yes products, but when you're talking to your GP about your moisturizers, about your lubricants, is to really look at the ingredients. So make sure the companies you're looking at have got an open ingredients policy. We want to avoid molecules like glycerin and glycols, the sugary products that can encourage things like thrush. We want to make sure the products are pH matched to the vagina. So the vagina is naturally quite acidic. And so you want to have a product that is matched to your vagina's natural pH. And we also want to make sure that the moisturizer and the lubricants don't contain things like parabens, petrochemical derivatives, all the sort of things that might go into moisturizers that you would use on normal epithelium. So by that, I mean your normal skin. But the mucosal tissue of the vagina and the vulva is much more sensitive. It doesn't have that protective layer, which is called the stratum corneum. And it means that it's much more vulnerable to the things we put on it. So it's just about trying to take note of what's in the products you're using. And so that was a sort of whip through of the moisturizers and the lubricants. But I've also got with me a physical product, which is quite a nice one to bring in, I think, at this point, which are the dilators. And the dilators, so dilators are little braided instruments. They go up, this is a sort of a size 1, so really small. It's about the size of my little finger. And this would go up, this is a size 6, and they would go up to about a size 8. And these are soft silicone dilators, and they are really useful if you're experiencing atrophy and you're getting real soreness around the entrance of the vagina. And they're a really good way to reintroduce gentle penetration and a gentle stretch of the vagina, and help reduce anxiety associated with pain from penetration. So you can work up through the dilators. So they're a nice physical device to know about at this stage, I think, if you're managing the atrophy and the soreness that comes with penetration. So I thought I'd just bring those in at that little point as well. Okay.
Brilliant. Thanks, Eleanor. That's great. And I've just pasted a link into your website, Eleanor. There was a question on the brand name. So I've just put a link into the chat that takes you through to the collection of lubricants that Eleanor has on her website, and you can see the yes products there and the pricing as well. So yeah, it might not have been obvious when I typed in yes that I was actually typing in the brand name into the chat there. While we were having this chat, Carol, thank you for your question. Claire, probably a question for you. Carol says she was prescribed 15 grams of estradiol, but told by her GP that she could take this for 3 months max, as it would create a lining in her womb. Is that correct?
No. Okay. So in the olden days, there used to be some stronger types of vaginal estrogen. And the issue is, if you have a womb and you take estrogen hormone replacement therapy into your body, the lining of the womb can thicken, and down the line, in the long term, that can increase your risk of cancer of the womb lining by a small amount. In the olden days, type of estrogen that used to exist were really quite strong, and so there was some evidence that the vaginal estrogen could cause a degree of thickening of the womb lining. But the estrogens that we prescribe now, the risk of that is so small. And the National Institute of Clinical Excellence, in their latest guidance, which was published in 2015, came out and said that you can use a vaginal estrogen for as long as you need to. And I think that's really important to consider, because frequently, and it really is frequently, it can take 6 months, it can take longer, but definitely a minimum of 3 months really to turn around symptoms, particularly if you really have lost elasticity. And so there is this slight anxiety still in the back of some doctors' minds about the safety of vaginal estrogens, but the data concerning the sort of the latest vaginal estrogens that we're using, which are really low dose, is really reassuring, and so you don't need to stop it after 3 months, and actually you might only be seeing the benefit at 3 months.
Thank you, Claire, for that. If anybody else has any questions, if you want to pop them into the chat, and we will either pick them up as we go through or at the end of the conversation as well. So moving on then, clearly if you are having pain when you're having sex or vaginal dryness, it's not going to be much fun, which could easily lead to a lack of desire or loss of libido. But assuming, you know, you've taken great treatment advice, you're using some of the products, Claire, we know that loss of sex drive is still an issue for many women. We mentioned research studies that shows that around 40–50% of women experience loss of sex drive related to the menopause. And before we come into the reasons for that, I think you would see, and as you're treating your patients, that, you know, a healthy sex life is really important to most relationships and to our physical and mental well-being as well. When you see patients in your clinic and they come to you with loss of sex drive, how do you generally approach treatment, or how do you think about really helping them get it back?
Yeah, so it really depends on what's going on. So I know that sounds obvious, but there are so many reasons in the menopause why your libido can take a hike. I think the first thing would be to understand exactly what libido is. So this is really basic, and it's a shame that Sue can't join us, but libido is generally split into at least two bits of it. So there's that desire to have sex, that sort of having some fruity feelings, just thinking that, oh yes, thinking about sex in a positive way, shall I say. And then there's actually the physical having sex and arousal, the physical response that your body is having that allows us to enjoy sex. And with age, with the menopause, and I stress with age because this happens to both men and women as we gain years, not everybody, but it is so common, as you've said, Helen, that desire can really reduce in some women down to nothing. So there's absolutely no desire. But actually, when you ask, you say, look, I know that the desire's gone, but if you had sex, do you get the physical response? Can you still enjoy it? Actually, the answer is often yes. And so the first thing is to sort of appreciate that that's what is often going on for people. And there is a bit of a positive feedback mechanism. And I'm really, really not suggesting that you should have sex if you don't want to have sex, but just maintaining that physical intimacy, just not taking that loss of desire to mean, you know, that doesn't mean any form of physical intimacy. If you do maintain that physical intimacy, you know, if you are pleasuring each other or pleasuring yourself in whatever way you're comfortable with, actually that can have a positive feedback effect, and your desire can start to increase with it. So there is a bit of a positive feedback in what's going on. But just with regards specifically to the menopause, there is so much going on, isn't there, that can really interfere with libido. You know, there's a whole body image and how you might feel about your aging process. There are menopause symptoms, hot flushes, aches and pains. For some women, it's a bit of a leaky bladder that can really interfere with how you feel about yourself and really get in the way. So, you know, if people are really tired, if they're not sleeping, if it's hot flushes, then the first approach obviously is, right, let's sort that bit out. What can we do? What can we offer to help that? And then, as we've said already, there's the physical issues. And you sometimes find that a lot of anxiety can start to surround sex itself, and that can have a subconscious effect on our bodies, making sex even more difficult. So you get in a vicious cycle where you're thinking, you're worrying about having sex, you're worrying about your partner wanting to have sex is painful or uncomfortable. And then subconsciously, your vaginal muscles, so the ring of muscles around the vagina, can start to contract, meaning that sex is even more physically difficult. So often, the point of saying that is there is a sort of vicious cycle of what's going on in your mind and your brain, and that increased anxiety, as well as the negative thoughts, translating into a physical effect, which is where Eleanor's dilators can often be really helpful to get your vagina used to sort of basically accepting something into it again, just learning to relax the pelvis. So I think in summary, that's a long answer to your question, Helen, but there is so much going on that it's really taking a careful history and trying to work it through. And I haven't even touched on relationship issues, therefore, of, you know, having been to maybe with your partner for a very long period of time, maybe getting a little bit bored with what you're up to, maybe needing to shake things up a bit and try something new in bed. Sue wrote a brilliant blog that's on our website that I'm sure we'll link to, which sort of talking about trying to keep things fresh as well. So I think in summary, it's really complicated, and you really need to try and get to the bottom of what's going on.
Yeah, and if we kind of unpack this a bit, and I'm going to pick up on a question that's come in from Anna, because I think it touches on what both you and Eleanor have been saying, Dr. Clare. And this links to cervical smears, and obviously really important for women in their 50s and 60s to continue getting their smear tests done, but obviously they can become more painful with age as well. So maybe, Eleanor, if we come to you first, maybe with a question around the just a recap again of, you know, the question that Anna has here is, would the products that you've mentioned, or the products that you would mention or recommend that could help with an overly tight vagina? And Claire, I'll flip back to you for medical treatment options with that as well. But Eleanor, some of the products that you've shown, or maybe others that you might want to refer to, any thoughts or advice for Anna here?
Yeah, absolutely. I think it's a really common problem, and I think we have two things going on around the time of menopause. So you've got the atrophy, so you've got the loss of elasticity of those tissues, which can mean that the whole area feels restricted. So you've got that physical loss as the tissue's dehydrated. There is a physical shrinking and an atrophy of that tissue. There is also the pelvic floor. So the pelvic floor, which is this basket of muscle that sits in the pelvis, and the vagina is one of the entrances that goes up through the pelvic floor muscles. Any muscle in your body, when there's pain, it has a job that is very protective. So if you get a neck pain, or we've all experienced sleeping on our neck badly, and your shoulder spasms, all your neck muscles spasm, and they do it to protect the joint from further damage. Now, what happens when there's pain in the pelvic region? If those muscles really contract, and they can make sex and penetration virtually impossible. So that's a condition called vaginismus, which is just this global contraction of muscles, which is driven further by the anxiety of sex is going to be painful, or this activity is going to be painful, which introduces further contraction. So you get stuck in this cycle. There's another term that you might come across called dyspareunia, which is actually referring to when sex itself is painful. So some people can experience global pain all the time, other people when there's penetration or there's attempted penetration. So talking about the products that will help, I would say lubricant, that you just cannot have enough. I think if everything's really slippy, that is a really good starting point. So don't be afraid to get out the lubricant. It's great if you can talk about needing to use it with your partner. I know some people feel nervous about introducing lubricant because they think it will reflect on a lack of desire, but actually that's not true. And if we can help men to understand what's going on in our bodies as well, the fact that you're not lubricating naturally is not anything to do with desire at this point. It is to do with the lack of a hormone in your body. So I think if we can talk about that and introduce some lubricant, that is going to help, especially when there is even soreness in the vulva everywhere. A really nice combination is putting the oil-based on yourself, in yourself, and then putting a water-based on your partner or on your dilator. And then the oil and the water will actually slip over one another, which is a lovely, it really prevents any sort of friction. In terms of managing that vaginismus, dilators are really, really useful at this point. So I would suggest using dilators initially on your own. Start with the smallest dilator that is comfortable. So that may be for many people, this little one. So you can see it's about the size of my little finger. Loads of lubricant. Lie really comfortably, quietly, where you're not going to be disturbed, and just insert it and do some breathing exercises. So try and do that diaphragmatic breathing with your stomach, and try and relax those pelvic floor muscles, and you will cue your brain to remember that this isn't a painful experience, and that will help with the down training of the pelvic floor. You'll also get the slight stretch effect on that tissue that we've talked about is slightly shrinking. So you're going to get that stretch effect on the tissue locally, but most importantly, you're going to be working towards down training the pelvic floor. Then what you want to do in over time, so it might be for some ladies over the course of weeks, you would then grade up to the next size up, which is a very gradual increase, and the next size and the next size, until you reach a size that you feel is comfortable enough either for you to then enjoy a vibrator, if you, or whatever your goal is, whether it's full penetrative sex with your partner, whether it's a vibrator, whether it's just going for a comfortable smear test. So I think they're really good tools to have in your armory. Another little device I've got here, which is maybe a good one to introduce at this point. If penetration, deep penetration, is painful for you, and that is what's making you anxious, we've got a lovely little product here called the O-Nut. I know, Helen, you like to call it the donut sometimes. But this is a set of 4 silicone stacking rings. So they're really stretchy, and they just sort of clip together, and you can see they've got a really good stretch on them. And what these are to help control penetration depth. So they're going to sit on the base of the penetrating partner or on your dilator, and they will create a really comfortable natural buffer, so that when penetration happens, it doesn't have to reach a depth that is painful for you. So these are called O-Nuts. They're available in a couple of sizes, but they're a really lovely device. And these were actually designed by a lady in America who was experiencing painful sex. So they're designed by necessity. And I think she's just done it. I just really love this product for that particular reason that you were talking about. I just think they're a really innovative little product. So that's the O-Nut. So there are things like this out there. I know a lot of the clinicians I work with recommend a very small vibrator called the Slinky Pinky, and that's a really so some people find the vibration action of the Slinky Pinky or a small vibrator actually down trains the pelvic floor. It sounds counterintuitive. So instead of a very small dilator, you could use a very small vibrator instead. So it's about finding the tools that works for you, and ideally chatting to your doctor, chatting to your physiotherapist, so that a pelvic health physiotherapist will be able to guide you with these sort of things, or your sex therapist. So, but hopefully that gives you a couple of little clues about the things we were talking about.
Eleanor, that was great, and I think you've answered another lady's question about how would I know what size dilator to use. So, and I've just posted some links to the different parts of your website so people can see more information. Claire, Anne raises a really important point about her smear tests being very painful. So what advice would you give to women who are in that situation as well? and how can they talk to their GP about making their smear test more comfortable for them?
Yes, that's a really good question, and a reason many women avoid having a smear, which is obviously really important in terms of cancer screening. So a top tip is to use a vaginal estrogen for anything between 6 weeks up to 3 months, maybe even longer actually, before your smear. So most experienced good practice nurses, and actually that's probably the first point, make sure you get your smear check done by somebody who's experienced. And if it feels like it's painful, the practice nurse will have seen it a million times before, and just say, look, I'm really sorry, can we stop? And you could ask them for their suggestions. Often they will be able, some of them can prescribe themselves, or they could just get the GP to prescribe you a short course of vaginal estrogen, even if you don't want to continue taking it. And then that would then make the smear, it will just increase the stretch of the vagina to then hopefully make the smear a bit more comfortable next time. Offering to sit, sometimes it can be quite hard for the cervix to pop into view, and after the menopause your cervix can shrink. And so sort of offering to sit on your hands tilts your pelvis slightly and can make the cervix easier to find. You can ask the nurse to use a small speculum. The speculum is the name of the instrument that we use to open the vagina. Or you could ask if there is a GP who specializes in gynecology. Like, for example, in my practice, I'm a GP as well, and the nurses will refer the trickier smears to myself, because you've got a few more tricks of the trade up your sleeve just to make it a little bit easier. So hopefully a few top tips there.
Sure, that's really helpful. And Ash, probably something maybe we might want to call out as well in terms of what Claire's just mentioned, because we know we've had that question from others. Now, one of the comments in here, and Beverly, thank you so much for mentioning it. It's a real shocker. And, you know, I'm really sorry that this is the feedback you've given. And Claire, I'm going to put this to you. Beverly was told by her female GP that there was nothing that could be done about her loss of libido. Now, clearly there is. So it would be great if you could maybe step us through what your recommendations are when you see a patient who is suffering from loss of libido. And clearly as part of that, you talk about testosterone, but I think it would be great to spend a few minutes on testosterone as well.
Yes, yeah, no, thank you for the question. So as I said earlier, the first thing is to try and work out what's really going on. And sometimes actually somebody like Sue, a sex and relationship therapist, is needed to really unpick what's happening within the relationship and as to why things are slightly going awry. Your GP can refer you to psychosexual counselling through the NHS. It's available in most areas, although as you can imagine, there's a long wait. Or it's booking yourself in, if you can, to see somebody like Sue Macon, a sex and relationship therapist. From my medical point of view, when I've explored all potential options that may to try and work out what's going on, my approach would be any vaginal symptoms, vaginal estrogen, really good vulval care as well. So avoiding soap, which can cause extra irritation, using soap-free wash down below, which I think Yes make one, and there are plenty in big pharmacies. HRT can help libido, so just your ordinary estrogen, and if you've still got your womb progestogen, there's good evidence that that can help libido by itself. And then the other trick, the other sort of sword in the armory is testosterone. So if you've really got no libido, testosterone can really make a difference. Most of the studies on testosterone were done in women with something called hyposexual dysphoric disorder, where there's absolutely no libido and no sexual pleasure. And the testosterone helped about 1/3 of those women. But actually, in reality, I think the numbers are slightly more optimistic than that. testosterone is off-license therapy for women in this country, which is why it's so difficult to get hold of. Most GPs, if I'm honest, wouldn't feel comfortable prescribing it. And the story with testosterone is quite interesting. Our level, so we all have testosterone floating around in our body, as well as estrogen. And the levels start to slowly decrease from your 30s, maybe even a bit younger. Instead of falling off a cliff like the estrogen does, it just slowly trickles down. And to some women, that doesn't seem to make any difference whatsoever. But to other women, it's the missing piece of the jigsaw. It does really make the whole difference. So my approach is always start with HRT. While you're starting HRT, you can check testosterone levels. I personally always check a blood level before I start testosterone, because some women do have naturally high testosterone levels. And if you give them testosterone, you increase the risk of side effects and it's less likely to work. So you can sort of gauge the dose, you can gauge what the response is likely to be. Testosterone can then be prescribed as either a cream, which there's a cream called Androfem. This is only available privately because it's imported from Australia. It's 1% testosterone cream, and it's it's not difficult to measure out from the tube with a little syringe, and you just rub it into the front of your thigh or your tummy, a tiny amount every day. The other testosterone that is available and can be prescribed on the NHS is called Testagel, or that's the most commonly prescribed one, or Testim. That's the same strength testosterone. It's still 1%, but it's a gel, and Testagel comes in a sachet. You have to squeeze out a tiny little pea-sized amount every day, smaller than your fingernail, and then you rub that into your thigh. So that is available on the NHS. The Androfem is only available privately. They're both the same strength. The Androfem is slightly easier to measure out. And you really need to use the testosterone for 3 to 6 months to decide whether it's worked. And actually, if it hasn't made any difference at 6 months, it's really unlikely to. So you probably would want to stop it at that point.
Thanks, Claire. I've just posted the article you wrote on the website about testosterone into the chat as well, and also the blog that you mentioned that Sue wrote about relationships and tips for relationships. And I know Sue will be devastated that tech prevented her from joining the call. Now we're approaching the last few minutes of our chat, so I'm just going back up through the questions that have come through. While I'm scrolling up, Claire, just a general question, one that I'm sure that you get a lot is, are there benefits to just taking, should we all just be taking HRT for general health benefits, even if not for any specific symptoms?
Yes, I know that's a $92 million question. So at the moment, it's slightly controversial, but at the moment, the British Menopause Society and the International Menopause Society don't support use of HRT for health preventative purposes only. So absolutely, if you take it to help your symptoms of the menopause, we know that the benefits by far outweigh any small risks. And in terms of risks, if you have the estrogen through your skin, which is called transdermal, there is no risk of blood clots, there's no risk of stroke. It significantly reduces your risk of heart disease and dying from heart disease. It significantly reduces your risk of fractures and osteoporosis. And that's balanced against a very small increased risk year on year that you use HRT for of breast cancer. But the benefits, particularly in your 50s, by far outweigh the risk. So it's the bioidentical progesterone, which I prescribe by the bucket load, has a lower risk of breast cancer associated with it than the synthetic alternative progestogens and things like Everol Conti. And in most of the tablets, there is a brand new tablet containing the bioidentical progesterone, which we can talk about at some point. But the benefits by far outweigh the risks in your 50s. So in answer to your question, it's difficult to say no, but we just need more data. And, you know, particularly as women age, as you go into your 60s, again, you keep all the benefits, but there's just a black hole when it comes to data and the balance. You know, the bioidentical lower risk hormones are relatively new in research terms. So we haven't got the massive randomized control trials that we've got with the older types of HRT, which at the moment are really still guiding those big national and international consensus statements. I think it really depends on the individual, what your risk factors are, what your circumstances are. And I think it's really hard to generalize. Sorry, that was a bit of a long answer to your question, but you can hear it's really complicated. It's not straightforward.
But it sounds like it's definitely worth having a conversation with your doctor and trying it out, because as you say, while there are risks, relatively speaking, the risks are still really small.
Tiny, yes, and many lifestyle risk, but the lifestyle risk factors are generally more important than HRT. So for example, if you have a body mass index of 30 or above, that more than doubles your risk of breast cancer. You know, if you take the older style HRT, that increases your risk of breast cancer by 5 extra cases per 1,000 on a background risk of 23 cases per 1,000 after 5 years. Sorry, 4 extra cases, where, you know, there are 24 extra cases if your body mass index was over 30. It was more risky having a glass of wine a day from that study than taking HRT. And that was the older, riskier type.
I think that context is really important, Claire, because if you think about it, a glass of wine a night, HRT, you know, so it gives you a sense of the size of it. And great timing with the questions from Siobhan here. Just asking Claire if you wouldn't mind repeating the best HRT in terms of lowest risk regarding breast cancer.
Yes, no, absolutely. So the estrogens are all much of a muchness. The vast majority of estrogen is estradiol. This, for example, is estrogen gel, or there's pump, or there's spray. The lowest risk form of estrogen is utrogestan, and this comes orally in little capsules. So utrogestan started with a U, or the combined oral with utrogestan tablet that is really brand new. It came out in September. It's called Bijuv, and in the next week or two we'll have some information on that on our website, but it's Bijuve.
Brilliant, thanks Claire. And I've just pasted a link there to all of the brilliant pieces of information that you've written about HRT and the website as well. And then another great question here: are there side effects to taking testosterone gels?
Yeah, so the majority of women don't, but potentially yes. So some women are just really sensitive to it. So the odd extra spot on the face, acne-like spots, the odd extra hair on the chin or elsewhere on the body. Coarser leg hair is not uncommon. Bushier underarm hair, bushier pubic hair, not uncommon. Hair loss, which is incredibly distressing, is listed as an uncommon side effect. I think the list is somewhere between 1 in 1,000, 1 in 100. I've probably spoken to 2 women out of literally hundreds and hundreds who thought that it's just made their hair loss a little bit worse. And that's more if you've got a genetic predisposition to hair loss. I think it possibly triggers it. But the vast majority of women have no side effects.
Okay, great. Thank you, Claire. Now, last few minutes, I'll try and get to as many of the questions that were put in the chat. I'm just going back up to some earlier questions first. I hope I'm pronouncing all of these names correctly, so bear with me. Apologies, Adele, if I get it wrong. Adele's question is: having eventually managed to get my GP to prescribe Vagirux with HRT, is there a maximum amount of time I can be prescribed these? She's very sadly struggled with symptoms for ages and doesn't want to lose the benefits of giving up.
Yeah, so Vagirux is a slightly lower cost version of Vagifem. So I think you get, correct me if I'm wrong, 2 applicators in a pack, and about 30, is it 30? I can't remember how many pessaries you get. So basically you reuse the applicator rather than Vagifem, where you have a new applicator for each pessary. And as I said before, the NICE guideline was really reassuring. and said you can use it for as long as you need it for. That the dose of estrogen from Vagifem and Vagirex is tiny. It's really tiny, and so never say never, but the risk is minute.
Okay.
You can continue it for as long as you need it for.
Brilliant. Thanks, Claire. I think that's really answered Adele's question. And then a question here from Elizabeth. All I get prescribed is Replens. Is this enough? And Elizabeth is 61.
No, at 61, you can use a vaginal estrogen. The only real contraindication to using a vaginal estrogen is if you've had breast cancer and you're taking a class of drugs called aromatase inhibitors. And even then, open to discussion. So as long as you're not taking an aromatase inhibitor, like Arimidex, for example, there's no reason why you can't use a vaginal estrogen, even if you've had cancer of the womb and had a hysterectomy. You know, even if you've had ovarian cancer, the vast majority of women can use a vaginal estrogen. Replens is a vaginal moisturizer, a little like the ones Eleanor was talking about. It may be fine, but you might need a vaginal estrogen as well.
Brilliant, thank you. And Elizabeth's got her smear on Monday. Best of luck with that, Elizabeth. Hopefully you got some great tips from Dr. Claire this evening on how to make it, I won't say a pleasant, but at least a less unpleasant experience. Claire, can yes, that's Eleanor, one for you guys. Can yes, is it available on prescription on the NHS?
Yes, I don't know what your perspective is, but where I work in Leeds, you're not meant, it flashes up a warning under the local health economy. On my list of prescribable medication, there's only the water-based one, but not the oil-based one. Yeah. Eleanor, what's your perspective on this?
So the vaginal moisturizer and the water-based lubricant are both available on prescription. Unfortunately, it is a bit of a postcode lottery, that thing we all hate, but there are some regions which are trying to push anything that can be bought over the counter. So a lubricant and a moisturizer can be bought over the counter, and they would rather patients self-fund that. So they can make it difficult. However, you have the right to choose the treatment you want to manage your menopause. And actually, the cost per use of a moisturizer and a lubricant is extremely cheap. And so, you know, if you feel it really is a product that is working for you, you can push to have it prescribed. And often it's a case of a decision being made in an office somewhere where your GP may be able to prescribe you a different product which is actually more expensive, but it's just ended up in a bit of a bureaucratic nightmare. So that the truth is, it can be a bit of a battle sometimes, and I have a feeling these conversations are going to get harder as the NHS pull back on all over the counter products.
Great, thank you. And then I think I'm going to come to the very last question and then hand back to Ash. So last question for you, Claire, from Carol. She doesn't really get hot flushes and doesn't take HRT, sometimes has painful sex. If she used estrogen moisturizers and so on, would that kick off hot flushes? I wonder, would that help with hot flushes, or do anything have an adverse impact on hot flushes?
So sorry, was that was the question, does a vaginal estrogen trigger hot flushes?
Would it trigger, and maybe just in case the question is the other way, will vaginal estrogens help with menopause symptoms too?
Yeah, so because the systemic absorption is so minute, I don't think I've ever come across anybody where the vaginal estrogen has helped hot flushes. Occasionally people think they're getting side effects from the vaginal estrogen, but you'd have to be super sensitive to the estrogen to get side effects from it. People occasionally do, but it's really uncommon. And certainly I don't think I've ever seen hot flushes as a result of a vaginal estrogen.
Brilliant.
I can't think of a mechanism how that would cause. I can't think of a mechanism by how it would trigger a hot flush.
Great, thanks, Dr. Claire. I think that's answered Carol's question. So thanks a million, Claire and Eleanor, and back to you, Ash.
Thank you very much to all of you for a really enlightening conversation. That was really, really helpful, and hopefully it's given all our members some really some great information that they can take back to their GPs if they need to. I do also just want to remind you all, and I've just sent a link in the chat box there. By all means, go to your GP and try and get help that way. If any of you would like to set up a private consultation with Dr. Claire or some of the other doctors that work for My Menopause Centre, you can do that through the link, through the Restless website, via the link that I've just posted, which is in our menopause section. So hopefully that will be useful as well. But we will be sending a follow-up survey for you all to fill out probably tomorrow. Please give us your feedback and let us know what else you'd like to hear with through our partnership with My Menopause Centre, and we will look forward to seeing you at the next one. Thank you, everyone. Have a lovely rest of your evening.